Welcome to the Teaching Value in Healthcare Learning Network. On one Thursday every month, we get to talk to an exciting innovator in the field that's working to make care better for our patients. We like to talk to people who are thinking about care in terms of better experience, better affordability, better safety. And our guest this month has done exactly that. So we're very lucky to have Marilyn Stebbins, who's a professor of clinical pharmacology at the University of California in San Francisco. She does teaching in the areas of Medicare Part D, innovative practice models, health policy, and leadership development. She also has an interesting role at UCSF as a vice chair of clinical innovation. So thank you so much, Marilyn, for joining us.
Thank you. It's great to be here. I'm really excited to share our innovation.
Great. Well, maybe you can actually just start off, because you've got this cool title. Maybe you can tell us a little bit about your background and what your role is at UCSF.
Sure. I've been with UCSF I'm in my 20th year, or starting my 21st year, but I had an interesting faculty position where I was remote. I was implanted 21 years ago into a physician group practice in Sacramento, so 90 miles away from UCSF, to initially start to help physicians who were in crazy managed care contracts that put them at risk for drugs, and they were losing money. So I was brought in to help them design cost-effective medication management programs, and it turned into Marilyn, quit telling us what to do and start seeing our patients and just help us prescribe cost effectively and help them. And so I had a wonderful 17-year career with this physician group that grew from 110 providers to over 400 and ended with 9 pharmacists, 17 technicians, and no pharmacies. So embedded to really work showing the value of cost-effective medication management and interprofessional team development in a medical group setting. My technicians were all advanced practice technicians, doing things like automated refill under protocol, doing stable patient anticoagulation. So we were really pushing out and getting everybody working at the top of their license. So interestingly, I decided with the Affordable Care Act and all kinds of things going on, I kind of wanted to come back to UCSF because I had a really innovative practice in Sacramento, and a lot of what I was doing there, I wanted to help facilitate at UCSF. And so I came back just about 4 years ago, and I actually got to pick my own title. So that's pretty fun. I've always been a person who has thrived on entrepreneurial principles, and I believe in, starting new, failing fast, pivoting, and moving on if it doesn't work. So I was able to come back, and my whole job is designed around program development, mostly in the ambulatory and community arena, and just trying new programs, seeing what sticks, and when they stick, hire young, energetic pharmacists to basically embed into teams.
So let's get into that so we can make it more concrete for the listeners. Obviously medication management can be very complex. There are huge ranges in costs, lots of discretion. And I imagine over the years, you've tried many things out. There was one in particular that we talked about earlier that we wanted to get into in a little bit more detail that has both a practice innovation component and an education component that's multidisciplinary. But maybe we can start off by just defining for the listeners what the main issue is that this innovation is aiming to solve.
Sure. I think the issue, so first of all, this innovation was around transitions of care. And the idea was when I came back and I really wanted to get into the space of transitions of care and look at practice development and improvement, I wasn't exactly sure who was doing that sort of work at UCSF. And I was able to get connected with folks that were, and we basically had a retreat that looked at anyone who said they were doing transitions of care work were invited. And we discovered at the end of this whole day session that we had 19 transition programs that knew nothing about one another. Many were started on grants and just kind of petered out. And if you had CHF, a patient could potentially be called by 5 different nurse case managers to talk to them without knowing the other ones were calling, just by the nature of our insurance systems. And so I scrapped the pharmacist-led program that I came to develop and said, who can I partner with so we can really look and see what are the medication challenges as people transition. And we were focusing on the transition from hospital to home. And I happened upon a group of nurses who were just getting ready to embark on a new technology, which was an IVR technology, so integrated voice response technology, to do a series of questions, ask a series of questions 48 hours post-discharge to anyone discharged from our hospitals. And I have to tell you, my first reaction was, this is never going to work. No one likes a robocall. You know, I don't think people are going to answer. But I have to tell you, my nursing partners were phenomenal in the rollout. They made sure that every patient at discharge knew this was happening. It was their opportunity to tell us if anything went wrong, and that it was a banner on their phone that said UCSF follow-up. So they did it right. And basically,
what did that phone screen aim to catch with those questions?
I'm going to focus on what it aimed to catch from the medication standpoint. So there were 7 questions like, do you have follow-up? Do you understand your discharge instructions? Were you satisfied? But the questions it asked initially were around primary adherence, which is, do you even have your drug 48 hours post-discharge? So the first question was that if you were prescribed a new medication or a medication at discharge, do you have it? And if you have it, did you start it? And do you have any medication questions or concerns? So what we did with this technology is the nurses were the first line of defense. So if anyone hit the buttons, and I have to tell you, every week running 3.5 years into it, we have over a 72% response rate. So that's huge. People are answering this call whether they have a problem or not. So when the nurses get it, they screen for, did they just hit a wrong button or not? But if it's a true medication issue, it escalates to my team. So, and my team is comprised of all kinds of learners. But then what we do is we solve the problems. But because I'm in academia, I wanted to study it, because I was told initially when I started this project that we really don't have medication issues at discharge because we don't hear about them. And I knew that that was not true because of my previous work doing some transitions work, and I know patients all have issues when they get home. So I wanted to quantify it, and so I studied it and looked at how people answered these questions. And about 20% of our patients at discharge had a medication issue, and 40% of those were related to access or just not even having the drug for many reasons. So the idea behind this program is, instead of putting in new transition programs based on what someone else has done, we wanted to fill the gaps figuring out where our holes were. And so by basically coding this data and figuring out what the issues were, we could then develop programs that would facilitate or basically fill these gaps. So as an example, because we had this high rate of people not having their drugs for various reasons, whether it's prior auth, script didn't transmit, you name it, they just didn't have transportation. What we did is we partnered with our pharmacy at UCSF, which is a Walgreens at UCSF, for a bedside delivery meds to beds program. And so we said, can we tackle this problem by instituting bedside delivery and ensuring that people have it? So I'm in the midst of studying the results of that now to determine how that affected our phone call program and does it improve access. And the preliminary data from my first 5 months of data is that absolutely these people.
So just to make it clear, so the access issues that the patients are having, is that due to affordability? Is it due to their health plan design?
It's due to all of the above. There's affordability issues. There are access issues in that they can't get there. Okay. There are prior auth issues. So we have it down to the granular detail. And then
quick question before we pivot to the education component, because you mentioned something intriguing, that you have all kinds of learners on your team that are involved in this. As you're going through this program, are you identifying opportunities to improve the prescribing behavior ahead of time rather than just catching the problems afterwards?
Absolutely. And I'll share with you really our new curriculum for our medical students, where they are actually in their first year having to do a quality improvement project. And I have a medical student on my team who's doing that. So the beauty of this data is I can see all the data. I know, and I can quantify which services in the hospital are discharging people. I know what drugs we have issues with. So as an example, my first year medical student right now is doing a project because one of our biggest problems is narcotics. So, and it's really not from an access issue as much as it is from questions, and they don't know how to start and stop them. They don't know how to titrate down. They don't know long acting from short acting. So, and they don't understand how to incorporate other pain meds with their narcotics. So my medical student is tabulating that data and coding it to look and see, are there certain floors people are discharged from that have common questions, so that we can then go back, and he will be helping me develop an educational program for the folks on that floor, for the services, the pharmacists, the nurses, and the providers, to address these concerns. And then we can again look at the data to see if these go away. That's awesome. That's exactly the process that we're using, is can we fix the things that we find to be issues?
And tell me a little bit more on the back end too. So I feel like there's a few things that sound unique about your approach. I mean, I think one is the multidisciplinary nature. So you've got medical students involved. I imagine you have pharmacy students, potentially others involved too. And during these transitions in care, most of our experience typically is in the inpatient environment. And we rarely have opportunities to have a window into what happens when we send patients home. So now let's say, you gave us an example of how you're trying to solve on the front end, but now on the back end, when an issue comes up, how do the learners get involved in solving those problems?
That's a great question. And that's actually what I'm most interested in is educating learners before they're out in practice to understand what the issues people have when they go home. So I have to tell you, this seems like a very routine sort of rotation for many of them. They're thinking, okay, what could happen? Probably the most impacted learners I've had so far are pharmacy residents who do most of their residency year as inpatient providers. Very little in ambulatory, and this is considered part of their ambulatory experience. And so what they know is we discharge the patient, we counsel them, and it stops there. But now what they're learning is they're running my service, basically. And what they're learning is we didn't do such a great job in discharging this patient. Nobody followed up on a prior auth. We think it was submitted, but we don't know. Once they're out our door, we don't follow them. We also don't know what's in the medicine cabinet at home that may be duplicate therapy to something we discharge them on, but a different beta blocker or statin. They also don't realize that all that great education they gave at discharge, they were giving it at a time when a patient wasn't necessarily able to listen. They weren't embracing that knowledge. They wanted to get home. They didn't feel well. And they really probably didn't hear us. Mm-hmm. And the other issue is they don't understand these after visit summaries that come with their electronic medical record discharge paperwork. And our medication lists aren't very good. We have a lot of duplicates, and we expect them to manage themselves based on these lists. So it's taught them really a wonderful skill as they discharge patients to think of all these issues and think of the patient once they're home, and sort of preempt many of these things that can be preempted if you follow through. Or how do we do a warm handoff? How do we do a warm handoff to the community pharmacist that's going to have to deal with this prior authorization, or the community physician who's going to see the patient in 2 weeks? Where do we do those warm handoffs? So I think that's really what we're trying to get to.
And one final question before we run out of time here. Do you believe, based on your own experience, or do you anticipate eventually you'll get to a point where there'll be some generalizable lessons that perhaps other institutions may be able to adopt similar approaches to getting their trainees involved in thinking about these transitions?
Absolutely. And I'm actually working within our ACO group with the other UC campuses that have just started using our technology the
Mhm.
same technology that we're using for the phone calls, trying to help them anticipate their issues and encourage them to have a multidisciplinary team. My nurses are fabulous on the front end of doing many of these calls, but what we've discovered working side by side is we answer questions very differently, and we learn how to utilize our team much more appropriately, because we now know what each other is capable of doing because we sit side by side. So I think that's a huge learning, is oftentimes we train together, but we still don't quite understand what the other healthcare team member really provides when it comes to value in care. And I think this is a great learning for everyone to understand, first of all, what's the pharmacist's role and what do they know that they can help safely transition these patients home, but also how do they fit into the team, and how can the team best utilize the pharmacist, and how does the pharmacist best utilize everyone else. So we're doing this with early learners. I've got first-year medical students, first-year pharmacy students, second, third, and fourth-year pharmacy students, and pharmacy residents. So we're really pushing this out to early learners so that we can get these generalizable things out there very early in their training, so that they can start thinking about how the team works together. And then when they're in the situation of discharging people, they can use these principles.
That's really great. And I salute you, Marilyn. This seems like really important work. And I think the general principle of having, different disciplines sit next to each other and try to get a sense of what's happening during these transitions is something that certainly the people that are listening to this can try to adopt. Maybe not in the same fashion. I mean, right. How much do you think this depends on the technology itself versus, another method of just following up with patients?
I think it depends. I think it's been incredible because the technology is really important, because wasting people's time calling someone
right
when they don't answer a phone is huge. And I did this program for 4 months prior to the automated technology, sitting with the nurses making these calls. And a pharmacist shouldn't be making half the calls here. We need to use our resources wisely. So I was asking questions they didn't need a pharmacist asking. So when you do that, and then people don't answer their phones, this technology cycles through 10 different times a day. It's really phenomenal. So
that's interesting. I wasn't even aware of this technology as a thing. So I think even putting that out there is...
It's amazing. I have to say, it's truly amazing. And the platform, wish we could get these things better integrated into our EMRs and not be separate platforms, but we're getting there.
Well, I think, with growing national concerns about healthcare costs and likely continued issues with affordability in the near term, the intent of this learning network is to share ideas and strategies in an open forum. And I think that this was a really wonderful addition. So thank you so much again, Marilyn, for joining us.